and welcome to today's lecture. Today we are exploring Chapter 7, Part 2, focusing on genetic diseases and inborn errors. Last lecture, we have covered environmental disruptions. Today, let's look at the error within the biological blueprints itself. In this section, we will shift our focus to genetic diseases, understanding how the blueprint of life functions and what happens when there are variations or errors in that code. To understand genetic diseases, we must quickly review how genetic information is stored. The genetic material. Human development is directed by the information stored in our 46 chromosomes, which are arranged in 23 pairs. We inherited half of this material, the 23 chromosomes, from the mother egg and the other half from the father's sperm. The replication and combining of this DNA is incredibly complex. Mistakes during this process are very common, and in many cases, nature's response to a severe genetic error is spontaneous abortion early in the pregnancy. Chromosomal abnormalities. However, some major chromosomal errors are survival, leading to complex developmental conditions. The most well known chromosomal abnormalities is Down syndrome. Instead of having two copies of chromosome 21, the individual inherits three, a condition known as trisomy 21. This extra genetic material alters of course of development, resulting in a distinctive physical appearance, high likelihood of congenital heart defect, and varying degree of intellectual disability. Single gene defects. Most genetic diseases, however, don't involve whole extra chromosome. They happen at much smaller scale. The majority of inherited diseases are caused by submicroscopic defects in a single gene. These follow the rules of Mendelian genetics. If the defective gene is a dominant, now inheriting just one copy is enough to cause disease. If the defective gene is recessive, it requires two copies, one from each parent, to express the disease. Those with only one recessive copy are healthy carriers. Let's explore the inheritance patterns of dominant disorders. Autosomal dominant disorders. In autosomal dominant disorder, the defective gene is located on non-sex hormones, on non-sex, in non-sex chromosome, because it is dominant. Affected parent usually has one dominant defective gene and one normal gene. When they have children, there is a 50-50 coin dose of each pregnancy. The child has 50% chance of inheriting the defective gene and developing the disease. What do these dominant disorders look like in practice? A prime example is Huntington's disease. Huntington's disease, a devastating condition that causes midlife brain deterioration, leading to involuntary movement and severe psychiatric issues. Because symptoms appear later in life, individuals often have children before knowing they carry the gene. The other example include achondroplasia. Chondroplasia is a type of dwarfism, and Marfan syndrome, a connective tissue disorder causing extreme height and dangerous cardiovascular weakness. Recessive disorders operate differently and can often remain hidden in a family tree of generations. With autosomal recessive disorders, both parents are typically completely healthy. However, they are both carriers of a hidden recessive mutation. When two carriers reproduce, the genetic math dictates that for each pregnancy there is 25%, a quarter, 25% chance of having a child with the disease. A 50% chance of having a healthy carriers, and 25% of a child with two completely normal genes. For the autosomal recessive, because recessive genes rely on two carriers meeting, we often see these diseases cluster in specific populations. Historically isolated populations tend to share more genetic traits, including recessive mutations. For example, Tay Sachs disease historically predominated among Jewish population of Eastern Europe descent. Sickle cell anemia is predominantly found in individuals of African descent. Cystic fibrosis is most common in Northern European ancestors, and thalassemia in the Mediterranean, Arab countries, or Asian population. Public health focuses heavily on these demographics for screening. X linked disorder. The final major inheritance pattern involves the sex chromosomes. In X linked disorder, the defective gene is located specifically on the X chromosome because females have two chromosomes. A healthy gene on one usually offsets the defective gene on the other. Males, however, only have one chromosome, XY. If a male inherits a defective X chromosome from his mother, he has no backup and he will manifest the disease. Classic examples include hemophilia and Duchenne's muscular dystrophy. Neural tube defects. Not all birth defects are purely genetic or purely environmental. Often they are an interaction of both. Neural tube defects, such as anencephaly, where the brain fails to develop, and spina bifida, where the spinal cord remains exposed, are caused by genetic predisposition interaction with maternal nutritional deficit. And this disease, we will discuss it in details in the course of nutrition through life cycle. This brings us to a massive public health success. We discovered that fortifying the food supply and supplementing pregnant women with folic acid dramatically reduce the incidence of these defects. Understanding these mechanisms allows us to intervene. Let's move to our next section: the genetic and newborn screening, prediction, and early intervention. This is where clinical practice and public health intersect to predict risks and provide early life saving intervention. Prenatal diagnosis. Intervention can begin before the child is even born. Prenatal diagnosis has advanced significantly. Procedure like amniocentesis involve using a needle to extract amniotic fluid, which contains fetal cell. These cells are then karyotyped to check of chromosomal abnormalities like Down syndromes. Historically, this was advised only for women over 35 due to procedure risks, but with advancing safety and non invasive blood tests, screening is now recommended for all pregnant women. But this occurs not on all the countries, because there is religions, different religions, and some religions like Islam prohibited or banned this procedure. Even better than prenatal diagnosis is a preconception screening. Carrier screening program aim to identify healthy adults who carry recessive mutation before they have children. The Thai SASH screening model is a gold standard. By testing high risk Jewish population, the incidence of the disease fell by 90% in North America. Programs like Door Yushorim take a culturally tailored approach, offering uh, anonymous testing to Jewish youth to ensure genetic compatibility prior to arranged marriage. If we cannot catch a condition before birth, we must catch it immediately after. This is the realm of newborn screening. Dr. Robert is considered the father of newborn screening. In the 1960s, he developed a simple, brilliant, brilliant, brilliant method breaking a newborn's heal and collecting a few drops of blood on a special filter paper. This allowed for rapid, cheap testing of metabolic diseases. Today, newborn screening is a public health mandate in most countries, designed to catch invisible disease before they cause permanent harm. Phenylketonuria (PKU), the disease that started the newborn screening revolution, was PKU. Phenylketonuria or PKU is a genetic inability to metabolize amino acids called phenylalanine, which is found in normal milk and food. Without the enzyme, it builds up to toxic level, causing profound mental retardation. However, it caught by the Dr. Robert test with, within days of birth. The infant is placed on highly specialized low phenylalanine diet. The brain develops normally and the child lives a healthy life. It is the ultimate public health success story. Our screening capabilities have expanded exponentially since Dr. Robert Guthrie time. In the 1990s, the introduction of tandem mass spectrometry revolutionized public health labs. Suddenly, from the exact same single blood spot, machines could screen for over 20 different metabolic disorders simultaneously. While technological amazing, it raised complex ethical dilemmas. Should we mandate screening for extremely rare conditions if we don't yet have effective treatments for them? Cystic fibrosis screening. One of the conditions added to modern screening panels is cystic fibrosis. Cystic fibrosis is a lethal genetic disease causing severe lung and digestive issues, affecting tens of thousands. Thanks to early newborn screening, we can identify infants with cystic fibrosis mutations immediately. We can intervene early with aggressive nutritional support and physical therapy. As a result of this proactive care, the life expectancy for cystic fibrosis patients has skyrocketed from adolescence to well over 46 years. Looking past infancy, genetic science is now transforming adult health care. Final major topics: genomic medicine. This represents the shift from treating the symptoms of a disease to predicting and targeting the genetic root causes of illness. This era was entirely ushered in by monumental scientific achievement. The Human Genome Project successfully analyzed and mapped the vast majority of the human DNA. By reading the blueprint, scientists have been able to identify the specific locations of genes responsible for health and disease. This has moved us beyond simple Mendelian traits and into the complex world of assessing individual risk for late onset adult disease. How does this map translate into actual patient care? We see genomics in action every day now. In oncology, screening for the BRCA1 and BRCA2 gene mutations allows women at high risk for breast and ovarian cancer to opt for rigorous early screening or preventive surgeries. In endocrinology, genetics markers provide hope for detecting type 1 diabetes early enough to stop the immune system's attack. And in pharmacogenomics, doctors can test your DNA to predict exactly which blood thinner or antidepressant will work best for your specific biology. Of course, this technology has not stayed in the doctor's office. Direct to consumer companies allow the general public to mail in their saliva and receive a profile of their single nucleotide polymorphism. They use this to estimate risk of Alzheimer, Parkinson's, and heart disease. However, from a public health perspective, there are massive concerns. The predictive science is still early. The industry lacks strict regulation, and studies show that telling someone they are genetically at risk doesn't usually motivate them to change their unhealthy behavior. Despite the consumer concerns, the clinical applications of genomics are saving lives right now. The true promise of genomics is targeted drug therapy. Instead of using a pro toxic chemotherapy that kills all fast growing cells, we can now genetically sequence a patient's specific tumor. Drugs like Gleevec were designed especially to block the mutated protein causes certain leukemias. We are designing drugs that precisely fit the genetic lock of the disease, resulting in much higher survival rates with far fewer side effects. As with any powerful technology, our specific capabilities have outpaced our social policies. In our final section, we must address the ethical and social issues of genomic medicine. Unlocking the human genome is somewhat like opening Pandora's box. It contains incredible cure, but also profound risks for discrimination and harm. Public health must always remember its past mistakes to avoid repeating them. In the 1970s, the United States launched aggressive, poorly planned screening program for sickle cell trait because the community was poorly educated on the difference between being a healthy carrier and have a disease. Massive discrimination occurred. Healthy careers were wrongly fired from job and denied life insurance. Today, sickle cell is handled properly as part of standard newborn screening with strict privacy and immediate prophylactic penicillin provided to save children's lives. To prevent the discrimination seen in the 1970s, federal legislation was required. In 2008, the United States passed GINA, the Genetic Information Non-Discrimination Act. This crucial law prohibits health, health insurers from denying coverages or rising rates based on genetic predisposition, and it forbids employers from using genetic information in hiring or firing. The GINA is vital for public health because if people are afraid their DNA will be weaponized against them, they will refuse to participate in genetic research or in clinical screening. The conclusion. As we wrap up our lecture, I want to leave you with the core public health consensus. Genomics medicine is miraculous, but it is expensive and highly individualized. The public health mandate dictates that while we pursue targeted genetic therapies, the bulk of our resources must remain focused on traditional broad scale prevention, modifying environmental exposure and health related behavior like smoking cessation, prompting healthy diets, and uh, promoting healthy diets and encouraging physical activity will ultimately save more lives across the entire population than any single genetic intervention. That's conclude our deep dive into chapter 7. Thank you for your attention today. We have covered a massive amount of material from teratogenes and uh, tandem mass spectrometry to the ethics of DNA. Thank you again and see you in the next chapter. Goodbye.